So we have Dr. Jung and Dr. Hamashima available to take questions. We'll open it up to the floor for any questions or comments at this time. Yes, Dr. Rabkin.
Sorry, sir.
I have a question for Dr. Jung. Thank you very much for that excellent talk. I was wondering if you could tell us a little bit about the Korean use of eradication in screening, both prior to initial screening and after, as a response to screening findings.
Korea expert eradication for atrophy and gastric just started 2018. So before 2018, we should follow the government indication for the eradication. So I don't know exactly for your system. One is eradication and another is endoscopic screening program. I'm sure both probe will very much reduce the incidence and the mortality of gastric cancer. But I'm not sure how much.
Yeah.
Thank you both for the presentation, all three of you, but the two of you that are here. For both of you, and I think both Dr. Hwang and I have been to visit Dr. Jung and Asan to watch you do endoscopy and ESD. So I think that Dr. Jung alone might attribute for some of the mortality drop in Korea. But in any case, what percentage of gastric cancer screening is done unsedated? Is it 100% or close to 100% in Japan and Korea?
Thank you.
In Korea, it depends on the patient side. So,
ESD.
Sorry?
Sedation.
For the under-conscious sedation, maybe you can have a much higher sedation. So I would recommend for the patient side be conscious sedation, but for the subject who have less response, the gag during endoscopy, they are right without sedation.
I have one comment and then a question for Dr. Hamashima. I think for those of you who are listening to Dr. Choi's slides and his randomized trial of H. pylori, you might say, how can they even do this, right? So interestingly enough, in Korea, it is actually not the guideline to eradicate H. pylori until after they've developed gastric cancer. I think that Dr. Jung, a lot of us are just perplexed by this, but it is still not a Korean health policy to eradicate H. pylori until the cat's out of the bag. So that's why Dr. Choi is actually able to do this randomized study, offering this randomized control study looking at H. pylori. It's very unique, and I think he'll get the definitive answer on H. pylori eradication. My question is to Dr. Hamashima, and you've heard all these presentations, and one of the reasons that I asked you and Dr. Choi and Dr. Jung to come is really to provide us with advice. You're probably 20 to 30 years ahead of where we are here in the US in terms of trying to propose gastric screening guidelines. And so, from what you know now and what you've heard from the morning's presentation, what would be some advice that you would give the U.S. committee on how to proceed, and maybe some mistakes that you guys made along the way, and some things to avoid, and some things that you really recommend that we focus on?
Sorry, first question answer. About sedation.
So I think
I answer the first question related of sedation. And in Japan, our quality assurance manual did not recommend sedation use at endoscopic examination. However, some physicians use sedation when they do endoscopy examination. In my experience, probably sedation use at endoscopy examination is only 2 or 3%. Second, based on our experience, and it is very difficult to recommendation of new technique. Then when we published the first guideline for gastric cancer screening, we cannot recommend endoscopic screening for gastric cancer. At that time, most gastroenterologists cannot accept easily our result. Therefore, they believe endoscopy examination can easily diagnose early cancer and a lot of cancer compared with radiographic screening. However, at the time we have already got similar result many case control and cohort study. Therefore, we compare the actual evidence. We cannot decide. We decide endoscopic evidence was insufficient. After that, we prepare the evaluation study at local area and accumulate evidence step by step based on the APP process. Therefore, such a step-by-step process is needed to establish cancer screening using a new technique. And when we also referred a Korean and Chinese study based on the systematic review, when we developed cancer screening guideline, it was very important to consider local context in Asian countries. Actually, there is a lot of evidence of cancer screening published worldwide. However, when our original guideline, when developed in Japan, I think local evidence is very important. It was, even if it is not RCT. Actually, gastric cancer screening has established based on the case control study and cohort study. This study was limited. This evidence is limited, but all study is a suggested positive result, and the result is these results were obtained real-world setting in Japan. Therefore, we think this result is very strong, can be strong evidence in Japanese context. Therefore, I recommend collaboration with similar context countries is important when we developed original guideline.
Fantastic.
Okay.
Yeah, one more question.
Question for you, Dr. Hamashima. What are your recommendations in Japan for biopsy protocols in endoscopy?
So his question is, how do you biopsy? How often? How many locations?
Biopsy is in our quality assurance manual, we don't define the biopsy rate and biopsy location. This is, however, we consider below 10%, below 10% is accepted a rate of biopsy. Around 5% is preferable rate for biopsy. The rate control usually conducted by local committee, and they suggested adequateness or inadequate adequate rate of biopsy, because some medical office is higher biopsy rate, other is lower. Such a disparity is needed control of endoscopic examination quality.
It's actually a really important question, and might be the differentiator between the West and the East.
So
Sorry.
if I'm understanding that correctly, 19 of 20 procedures are expected to take place with no biopsies,
Yes.
and that's considered a good rate.
Yes.
And I'll expand on that. So they are very into visual diagnosis, so endoscopic diagnosis, and because biopsies do have consequences, they scar tissue, and if we want to do ESD, it makes doing endoscopic resection much more difficult. And so if you go watch endoscopy in Japan, that's why they really ruminate on essentially endoscopic biopsies and doing a very careful examination, whereas us in the U.S., we're you have the Seattle Protocol for Barrett's, right? We just love to biopsy, and so I do hope and I do envision a future where we're going to become more Asian the way they do it. I think it's, especially with imaging technology, us being able to visualize things better, characterize the mucosa. The idea really is to take targeted biopsies as opposed to just purely random biopsies, at least for this type of, the intestinal type. For if you're talking about diffuse type or signet ring cell type, where it's more deep and not superficial, then you're still dependent on deep random biopsies. Yeah.
Just to add, I spent some time also in University of Tokyo and the National Cancer Center in Japan watching endoscopy, and essentially no biopsies were taken. On the other hand, 60 to 80 photos where you could reproduce the map of the entire stomach was taken. So there is something, I think, to learn from each other about how to best do this. And for example, as American gastroenterologists, we focus on slow withdrawal in the colon, but not so much in the stomach. So I think there's a lot to learn here.
Okay, this will be the last question.
Okay, it's more of a comment. Is that still okay? All right. I'm Rick Peak from Vanderbilt. So I just wanted to say that there's a lot of momentum moving towards this. There was an article in Gut that was published within the last few weeks showing that there was credibility to an endoscopic staging system for the progression of intestinal metaplasia. It was very closely tied to the predictive value that OLGIM has, and if it's validated properly, I think that their intent was that this would reduce the number of biopsies that you had to take. But the things they didn't take into account was, whether or not this was going to lengthen the procedure. And it's an endoscopically based system using high definition chromoendoscopy. So, I think that there are things on the horizon that are going to move towards this, not taking as many biopsies and really using an endoscopic grading system. And the scale was from 0 to 10, and it did very well as far as predicting gastric cancer progression. So.
Excellent. Thanks, Dr. Peak. So I wanted to thank again Dr. Jung, Dr. Hamashima, Dr. Choi for joining us both live and electronically. This is really, you've created a signpost for us to move forward in the United States, which we'll be talking about a little bit later this afternoon in our advocacy session. So thank you again very much. So we are going to have lunch now for about 45 minutes. We're going to reconvene our afternoon session very promptly at 1 p.m. The Dean Lloyd Minor, is coming to deliver remarks at 1, so we have to be very punctual for that. And so thank you again, speakers.